Well, ladies and gentlemen, a very warm welcome back to the eCancer series on cancer conflict in Ukraine. I'm Richard Sullivan from King's College London and also the chair of the eCancer Trustees. And it's a great pleasure to welcome back to eCancer a good friend and colleague, Professor Jacek Jasim, medical oncologist from the University of Gdansk and also president of the Polish Cancer League. Jacek, we last spoke, I think it was April, almost a year ago on this topic. Very warm welcome back. Thank you very much indeed for talking to us today. Let me begin by just maybe asking you to really just tell our listeners a little bit about the experience you've had in Poland since we last talked in April. There's been a huge, obviously, dynamic changes within the Ukrainian war. We've seen refugees ebbing and flowing across borders, lots of complex movements. What's your perspective and take been on this?
We talked a year ago, so it was shortly after the Russian invasion to Ukraine. And of course, the situation was very difficult because this was something unexpected. We all believed it would never happen, but it happened. So we had at that time a flood of uncontrolled Ukrainian refugees who arrived to Poland and other neighboring countries, but the highest number arrived to Poland because Poland is the largest country out of all European neighbors of Ukraine. And of course, among them, we had cancer patients who started their therapy in Ukraine or were diagnosed in Ukraine and had not started yet their therapy. So we had to manage. And of course, it was not easy since Poland already had some shortages in healthcare. However, we had to deal with this problem. Of course, these patients necessitated usually quick service. So this, of course, we had to take into consideration the demography of these patients. By definition, there were no men at the age of 18 to 60 because they were not allowed to leave Ukraine. So we had women, old women and men, and children. Most of the malignancies were women malignancies. This is statistics. The problem is that in Ukraine, there was no screening, so we had more advanced cases, for example, cervical cancer cases or breast cancer cases, which prevailed. So this was a relatively new situation for us because we don't see such advanced cases in our practice in Poland. So the problem was that we had to arrange new services for these patients, also to arrange some formalities because these patients were offered the same service as Polish patients, but formally they should have their personal identification number. So it took a while, but it was relatively well organized. So these patients within a couple of weeks received service in Polish cancer centers, and they included all types of services. So that means systemic therapies, radiotherapy, and surgery. As I said, we had to arrange it very quickly because hospitals were not prepared for this, but this was manageable. They didn't constitute large part of the normal volume, so it was a few percent, below 5%, I would say. So it was manageable. Adult patients arrived in completely uncontrolled way, whereas children were transported in groups. So it was much better organized. Of course, children malignancies constitute around 1% of all malignancies, so it was not a big deal. But we had groups, 20 or 30 children from, for example, hospitals located in the east of Ukraine, who arrived in a planned way to dedicated hospitals in Poland. So this was very well organized. Individual patients produced some problems because we didn't have translation services organized at the very beginning. These patients came with Ukrainian documentation, Sometimes they arrived without any documentation because the documentation was lost during the war or was completely incomplete. There were big difficulties in contacting the doctors in Ukraine because some hospitals were not in operation. So there were many, I would say, management issues we had to solve, which now are much better addressed.
I just wonder if I could pick up on something we discussed a little bit last time, which is the complexity of the clinical management here. Last time, I think you alluded to the fact that patients maybe had been started on one fractionation regimen, potentially with a Cobalt 60 machine, and been planned on that, and then suddenly appearing halfway through their treatment at a Polish cancer center. What are the learnings you've had from this sort of discontinuity and these very different, often standards of care? What have been the major learnings?
These are individual cases, of course, and we had to consider them individually. There were various scenarios. For example, if the patient started their therapy in Ukraine, and if we talk about radiotherapy, they received one or two fractions, it is not a big issue because then the patient was planned again in Poland and started therapy in Poland. It was the more difficult situation was when the patient received, for example, a half of therapy, and we had to define the treated volume, the dose, and so on and so on. Indeed, most of these patients are irradiated in Ukraine with cobalt units, which are not in operation in Poland anymore. So these were individual situations we had to solve. Sometimes it was really tough because, as I said, contacting Ukrainian doctors and getting this data was very difficult, if possible. So this was in the hands of doctors how to manage it. We did our best. We learned, for example, from patients how many fractions they got and so on. So we assumed, for example, if they got 10 fractions, it means 2 gray fractions. So, sometimes it was our experience to estimate the therapy they got. And of course, in most cases, we had to do a new planning. Even if they had some documentation, it was impossible to use planning that was done in Ukraine. This was I would say, the biggest issue, because if they started systemic therapy, we just continued therapy unless it was a scheme which is not in use in Poland, because sometimes patients receive therapy we don't use anymore in Poland. So we offered more modern therapy with drugs which were not available in Ukraine. Sometimes patients received excessive therapy in Ukraine. So it was difficult to explain the patient that, for example, chemotherapy is not necessary. In individual case, they had a feeling that they were refused therapy, which would otherwise save their lives and so on. So there were also some psychological issues. It was, again, a very personal differences, and we had to manage. We didn't have at the beginning a psychologist. Now we have quite a lot of Ukrainian psychologists coming to Poland as refugees or just coming to work in Poland because they have no possibilities to work in Ukraine, in some hospitals in the eastern part of Ukraine, which are destroyed or in danger. So this is also a very important issue, because this patient faced not only medical problems, but also social problems, psychological problems. Their families were in Ukraine, their husbands were soldiers, and so on. So we had to take into consideration their life situation, not only medical situation. Now the situation has stabilized. We don't have uncontrolled arrivals of Ukrainian refugees. I would say most of the refugees returned to Ukraine or went to not only European but also other countries. We still have around 2 million Ukrainians in Poland. 1 million are new refugees. Around 1 million arrived before the war. We have increasing number of patients who come to Poland because they have no possibilities for some therapies in Ukraine. They have shortages. Polish health system may offer them novel therapies, for example, immune therapy or targeted therapies, which are not available in Ukraine. So we have quite a lot of such situations. People in Ukraine already are aware that in Poland they may get better care than in Ukraine. So they are not only, I would say, related to the war as such, but due to difficult situation in Ukraine caused by the war. For example, in Ukraine, some medical therapies were not reimbursed even before the war, and patients could manage with the help of charity and so on, which is much more difficult nowadays. They feel in Poland, they feel safe, they can get this support, they can also get some social support in Poland. They have small money to survive in Poland offered by the Polish government. The system can much better address this new situation in Poland. And in fact, we consider this something natural. This is not surprising for us. We can manage. Some patients have been already in Poland for longer, so they can communicate in Polish, which is not very different from Ukrainian. So I would say the situation now has stabilized, and I think Ukrainian patients are satisfied with the care, which is identical to that Polish patients receive.
No, it's extraordinary because you described as the new normal now, essentially. And obviously, with no end in sight for the war, I guess my final question really is a sort of reflection on the sort of national cancer control planning across Poland. If this now is the new norm, if there's another major influx of refugees, do you think you're better positioned now than you were last year in order to be able to handle the complexities? What's your sense about what the future is for the sort of national cancer planning for Poland?
We have to take into consideration the scenario that we will have another flood. We were a little bit concerned with the possible flood during winter because the situation in Ukraine was very difficult due to the damage of power stations and other energy infrastructure. So we expected more Ukrainians during winter. Fortunately, the winter was relatively mild in Europe, so there was no increase in the number of refugees. But of course, this was, as I said, unexpected flood. Now we know that it may happen in the future, and the system is, I would say, better prepared for that. Investments in oncology are first expensive, second need more time. We are generally expanding our potential in Poland. For example, the number of radiotherapy units is continuously increasing in Poland. And the situation in radiotherapy is relatively good. I'm talking about radiotherapy because this is, I would say, the most difficult part in terms of investments and infrastructure. There are no long waiting lists, so if we have another 50% of patients, probably will manage. But generally, of course, we would need larger infrastructure to face these problems. Of course, it is very expensive. Poland has many problems, as all European countries nowadays after pandemic and due to the war. So we have to accommodate this needs into the general situation, economic situation of the country, which is in danger as everywhere. We have a plan of further development. We have an ongoing national cancer plan, which includes also the development of the infrastructure. And I would say the situation is under control now. I don't see big dangers. Of course, it could always be better. You are in the UK, so you know the problems of the UK healthcare system. We had similar problems, of course, but we do our best to manage.
Well, I think you've done more than your best to manage. It's been extraordinary how much Poland's done for Ukrainian refugees, and also you personally, how you've managed to drive the National Cancer Control Planning in Poland. And I just want to say thank you very much on behalf of eCancer for talking to us today. It's been fabulous listening to the work you've been doing and also the learnings. And I hope this is something that in time will be published as well, because I think, we all know in the future there will be other conflicts, and understanding how to care for cancer patients within conflicts is going to be one of those critical areas. But thank you so much for talking to eCancer today. We really appreciate your time.